My topic is breast-specific gamma imaging or molecular breast imaging. This is a fairly new thing in the United States. We have been performing this procedure for about 2 years. I would like to share some of my experiences where we use this in routine clinical practice, where we feel like this modality is going, and just give some examples of interesting patients. So a clarification I feel like was in order. Nothing will ever replace standard mammograms, and they save thousands of lives in the year. The United States, we typically recommend patients over the age of 40 get an annual mammogram, or if they have significant family history, begin at 30. Base those decisions on their physicians. We are trying to be an adjunct to mammography in patients that mammograms struggle, and also particularly in dense breasts. So the topics I'd like to discuss is what is breast-specific gamma imaging, who needs it, show you our protocol, how it works, provide you with some examples of case study, ongoing research projects we have, and then just some general problems. So what is breast-specific gamma imaging? It's simply a small amount of commonly used short-duration radioactive material. We use cestamide, same cardiac agent, is given intravenously in the arm. Due to higher metabolic activity of cancer cells, tumors absorb more of the agent and reveal focal areas of abnormality as increased activity. Since the radioactive tracer is used, it's not a routine exam. It is used selectively in certain clinical situations. A good example of when and where to use these, the Society of Nuclear Medicine put out practice guidelines last year. You can get that off their website. It is a very good detailed list of when and when not to use this material. Other tests such as mammography and ultrasound image physical structure. BSGI portrays actual cellular function. That's the key difference. Nuclear medicine, we're always looking at function. So, brief example, you guys actually just purchased the same system. This is a Dillon camera. Very simple, one-headed gamma camera that works very well. So who needs it? I know this is a long list, and I put in red the patients that we really use. Probably more than 80% of all of our patients are the ones in red. So that's dense breast tissue, elevated risk of cancer. That's our number one. Lesions that can be felt but not detected with mammogram ultrasound. That's a close second. I'm not going to read all of them, but basically anybody that can't have an MRI, a breast MRI, can have a molecular breast imaging, pacemakers, implanted pumps, other devices, severe claustrophobia, things like that. A lot of these patients that need a staging exam when they have a known cancer will do the breast-specific gamma imaging. And also lobular breast cancer. That is a very important point. Lobular breast cancers struggle to be imaged with some of the other modalities. MRI can very much not get a good estimate of size. And the breast surgeons want to know so they can know to do lumpectomy, mastectomy, breast conservation, things of that sort. Lobular grows in sheets around. It doesn't grow in masses. It doesn't do as much mass-like growth. So a key thing happened in 2012 in the United States. The U.S. government started passing laws saying that you need to educate women about the accuracy of the mammograms when they have dense breasts. So in my state, in Virginia, in July of 2012, you are required after an annual mammogram to send a patient a letter stating that their breast, if they have, we are required to put densities on our mammogram reports. So if they get a breast density of 50 to 75%, they now get a letter of saying how mammograms may not completely survey them for cancer. So once women receive this letter, what do? So here's an example. On the left is a fatty breast, normal breast tissue. On the right is dense. And you can just see it looks like just clouds. You can't really see anything. Both of these patients have a cancer in relatively the same location. So you can't see in the dense breasts that cancer. So our protocol, this is a very easy procedure to do. We set an IV, and If they have a suspicious activity on the left side, we do the right arm. You can image the axilla. The axilla imaging is not very effective, but we do it out of just try and do best practice. We inject 20 millicuries of cestamide. That is a relatively high dose for now. That is the FDA, our government body, approved amount. That dose is going down significantly. There are trials for 10 millicuries and 5 millicuries of cestamide, and we hope to lower the dose soon. Scanning could start within 10 minutes, and you basically do the same views as a mammogram. And sometimes you need to tile based on size and things like that. So an important point of hormones, close attention needs to be paid to the patient's cycle, and the status are important to good image quality. Hormones really change the appearance of the breast in imaging for molecular breast imaging. And I'll show you an extreme example in a lactating patient. So for example, we did a patient, a 35-year-old, she had 5-week-old infant, was diagnosed with breast cancer during her pregnancy, didn't go through treatment, but as soon as, after the child was born and healthy, we started treatment on this patient. The MRI wasn't helpful, and I can tell you, just as looking at this is completely worthless. You see patchy areas, you have no idea. It all looks like cancer. And I'll show you the normal in a moment. But as you can see, once the hormones and things get going on, it really damages the image. So here, I'll show you an example of a normal patient with a significant family history of breast and ovarian cancer, and they had a screening mammogram. So this is an example of a dense. So you see this cloud. This is a mammogram with greater than 75% density. Her surgeon felt like this was not an adequate way to screen this patient, so ordered a BSGI. This is a very nice, perfect normal. You have no concern whatsoever. It's the person feel at ease, and you can go about her screenings. So, as I said, this is a very nice normal, clear and consistent heterogeneous activity. Just like I said, one suggestion is you have to base patient scheduling on the cycle. It's very important, minimize hormone activity. You also have to pay attention to medications that increase hormones, anything for lactation, things like that. So I'll show you another example. This is a 48-year-old woman comes to the center for her annual mammogram after completing 8 annual mammograms in a row. Mammogram in the prior year, ultrasound that were benign. She came in January of last year for her annual mammogram. This is our worksheet that we use. The only reason I added this, she had some surgeries, biopsies, significant family history, but everything was always negative. So here was her mammogram. You can see density, densities all over. You can tell there's some, not able to quite pull everything into the field of view. That's a mole marker. That's just a challenging mammogram to read. And that's one of the key things when you do mammograms year after year after year, you go back and looking for changes. It's the whole point. Well, this was the report that was issued, and it's no suspicious activity. So BSGI was ordered. She is 50 to 75% dense with a symptom. She was having some nipple inversion. So the BSGI is completed. We set an IV on the opposite side of the suspected area, injected a small amount of cestamide. And just to note, the compression is about 75% less than a mammogram, so it's quite a bit more comfortable. Each picture takes 8 minutes. The entire exam takes about an hour to an hour and a half. These are time-consuming exams. So here is her BSGI. As you can see, the main point here is this activity. You can tell that we're kind of cutting. You can't pull everything into the field of view, but that is a large area of suspicious activity. And as you put them back together, you can see the suspicious activity was right in line with this cloudy sky. So in this patient, after 8 years of normal mammograms, focal and intense activity was found, and she was sent for second look ultrasound. When we first got this device, we thought that we would be doing a lot of biopsies with the camera, and found that really not to be true. You can do the BSGI, and the radiologist or nuclear medicine physicians can go back and understand right where they're looking with an ultrasound. So you're able a lot of times to go back with second look directed ultrasound and easily biopsy the lesion. So for this patient, and it's very interesting to me, this was in the second week of doing this, she had a 9-centimeter mass that was missed by mammogram. So she had larger than a golf ball in her breast that proved to be a cancer. So this switched the dramatic change for this patient, moved from neoadjuvant chemotherapy, surgery, and even radiation afterwards. Cancer would surely spread. So I'll show you another example of a 2.1 centimeter based on ultrasound, invasive ductal breast cancer of the right breast that needed a staging workup. The patient had a pacemaker, so she could not undergo an MRI, and a BSGI was ordered for staging workup. You can see this is a nice staging. You can see this focal and intense. This is the nipple, so that shows up as activity as well. This is a very hot area, very easy to see. But when we started doing this is the other side. You see this fairly focal activity in the other side, the left side. And it's the same as our standard practice. Went back for a directed ultrasound. Well, this was read as an indeterminate. The radiologists, we try and be very conservative in the reading of these exams. And there was also some uptake in the right axillary nodes. So the breast-specific gamma imaging showed a small area of activity in the contralateral breast. Patient went back for second look ultrasound, but we couldn't find anything. The surgery has changed. The patient was planned for a lumpectomy as she had a fairly small cancer. But due to the BSGI results and the radiology review, pathologists, they decided to go to double mastectomy. So dramatic change in the surgery on this patient. But based on the results, the radiologist, the pathologist got together and decided that they were going to go ahead and try and sample based on where they thought it would be. And proved to be worthwhile. They found a 2-millimeter invasive ductal cancer. So very, very small cancer was picked up by the BSGI. One more example, patient came to our breast center with a self-discovered mass, but mammogram and ultrasound could not reveal a problem. Patient was referred for a BSGI. There's another example of a fairly easy read. You see these activity that's relatively hot. They would have tried biopsy, they just couldn't find it. The second look ultrasound based on the BSGI directed the nuclear medicine radiologist in the area. This led to the detection of an invasive lobular cancer. When you start to do these, and the lobular cancers are the ones that's really challenging for ultrasound and mammography. This led to a lumpectomy and early treatment. So I can tell you a little bit about the research projects that we have ongoing and some of the clinical questions we have. Does breast-specific gamma imaging identify invasive cancer in women with dense breasts with a benign mammography? The goal is to find breast cancer early. Dense breasts are a risk factor of cancer in and of themselves. The Mayo Clinic did a large study that showed your significantly increased risk if you have dense breasts. So the project that we're undergoing right now is patients with a benign mammogram and 75% or more dense breast, 50 to 74% dense and a close relative with cancer, or a symptom. All of these patients will have a normal mammogram, and then we're following these. We hope to do 500 patients, by the end of the year, and then do some publications on this data. So some problems. How do you perform a BSGI on a woman that has significant risk factors in a negative exam, or how often? That is a clinical question that we're trying to answer. This is radiation exposure to younger women. We have to be very careful on exposing people. The one important point as far as radiation exposure in these people is actually to the breast, mammogram gives more dose. As nuclear medicine technologists, we understand Cestamibbe's target organ is the colon. That is the number one place radioactivity goes, plus thyroid, heart, gallbladder, all of the other organs, just GI. It's not the breast. So that's an important point as we're looking at it as radiation exposure to these patients. Follow-ups. Can we perform treatment monitoring exams to validate this practice? We have now moved in to patients that they know need neoadjuvant chemotherapy. We will perform breast-specific gamma imaging instead of MRI. MRI is still anatomic imaging. It is like a cancer patient getting a CT instead of a PET CT. We've found it is very easy to do a pre-chemotherapy BSGI, do their chemotherapy. Before they go in for surgery, do another breast-specific gamma imaging, and you will see if the chemotherapy is working. All of that activity will normalize. If you did an MRI, you would still see most of that activity still in a mass. That is still the difference of functional imaging versus anatomical imaging. That is where nuclear medicine and PET CT excels, is functional imaging. One point I would like to add as far as who does the procedure, we had a big debate in my institution of who did it. Do the mammographers do it? Do the nuclear medicine technologists do it? I can see this being a very challenging debate here because the physicians do the injecting. In my facility, it came down to the techs are the only ones that are allowed to touch radioactive material, so it was an easy choice. I can tell you, though, for the first year, I had both technologists in the room. You learn a lot from the mammographers on the difficult patients. A lot of these patients, you have a real challenge giving all the images that you need, and they're the real experts in MLO, all of these odd angles, and allowing the women to be comfortable in performing these exams. I found it very helpful for two people to be in there and to train the nuclear medicine technologists to perform the exams, because the mammographers really didn't have any information on radiation safety and things like that. So in conclusion, breast-specific gamma imaging is a very cheap, easy, and accurate way to identify breast cancer in women. And BSGI brings molecular imaging to the forefront of the fight to the diagnosis of breast cancer early. And that's and more education and publications are needed to change the common practice and to move past anatomical imaging and to use BSGI in the complementary role in standard workups. I can tell you in our practice, what we're doing now is alternating. If women have significant histories if they have a primary relative, which is a mom, aunt, or close family member with breast cancer, we will do screening mammogram 1 year, BSGI the next year, following by screening mammogram, then BSGI. We don't want to lose the anatomical information, but we also want the functional information that allows us to minimize the dose and still get good quality imaging for patients. And that's what I have. Thank you. Any questions?
James, any question for him?
Yes, sir.
I thought that 2 years ago there is a technology called PAG. Do you know the technology?
You mean PEM?
PAG, plasma emission mammography.
Yeah, PEM. Yeah.
This is technology you can do the whole body imaging, then you can do the mammography in the same dose.
Yes, I've used that as well. I have quite a bit of familiarity, excuse me, with PEM. PEM is an excellent, and I understand that you guys have both, which is a wonderful. And PEM, the spatial resolution is significantly better in PEM than the BSGI. It's a little more difficult in biopsy, but if you're already going to do the FDG PET scan, that's great. I can tell you in the United States we have some problems is they will not allow us to do a PEM on a preclinical diagnosis of cancer. So typically you're not doing FDG PET scans when you don't have a diagnosis. Our role that we feel for molecular breast imaging is diagnosis. We are trying to find cancers early. If PEM does great in staging, there's probably nothing better. If you know that patient has a cancer and you need to stage both sides, both breasts, PEM's perfect. Our role, we feel, the role of molecular breast image is on the diagnosis role. Is more closer to mammography It's trying to help the nuclear medicine and the radiologist as a diagnostic tool, as we talked about yesterday, using molecular imaging to find cancers at 2 millimeters. Not you have a 5 centimeter cancer and you're trying to stage both sides. So PIM is very good. It's very effective, but you can't go around injecting women with 10 millicuries of FDG when you just think you have a suspected cancer. You know what I mean? The dose is so much higher that, does that answer your question? Okay. Thank you. Anything else? Yes, ma'am.
If you want to image the two breasts, like say today you did the right breast, after 48 hours you're gonna image the second breast, or what is the gap between the two?
You don't need.
You still have the guts after 48 hours.
You don't need a gap. We do it at the same time.
Same time?
Yep. Well, you do.
Injection here and injection here.
No, you just one injection covers everything. So you inject and then you can image both sides. Yeah.
Thanks.
Yes, Giorgio.
As usual, ask a question. Have you some problem with intervening with extravascular injections that make you some false positive from breast, or never happens when you stage the same side? Because you say that sometimes you stage the same side. Maybe some problems with false positive on that, or you never face it?
No, absolutely. Any extravasation of dose is going to go into the axilla. It will look like a cancer. It's no different than a lymphoscintigraphy, or you basically what you did was you just did a lymphoscintigraphy, is you inject it and it's going to go up into the axilla. That is why in our protocol we said IVs on everybody. We did not do straight stick injections. So yes, you have to be very careful. But you still will have the common things. You can see a tract. You can see other lymph nodes showing up. But yes, you did need to be very careful that you did not create a lymphoscintigraphy exam doing breast-specific gamma imaging. Yeah. Anything else?